This chapter, titled Mood Disorders and Suicide, outlines the characteristic features of mood disorders. That includes major depressive disorder, persistent depressive disorder, double depression, bipolar 1 disorder, bipolar 2 disorder, and cyclothymia. Now, you may or may not be familiar with these terms, but by the end of this chapter lectures, I want to believe that you will be familiar with these differences and able to distinguish each mood-related disorder from another. Especially the epidemiology and etiology, the causes, and the treatment of these conditions are important that we will be talking in this chapter. Symptom features modifiers, like we will see what makes depressive disorder so complex, and we'll look at some of the specifiers or those additional factors that have implication for predicting course or response to treatment and remission of this disorder. This chapter is also devoted to the phenomenon of suicide, including prevention and intervention of suicidal ideation and their intentions. Various clinical examples are important that we will be talking throughout the chapter. An extensive discuss of the changes in mood disorder seemed in DSM-5 revision that come into play, and we also notice there are new added different diagnoses just to reduce that complex confusion between different disorders. And also we will look at these disorders comparing each other, trying to again identify those prototypical symptoms, what makes each disorder unique from the other. And when you treat or see individuals with these symptoms, can you make such distinction? Can you tell if somebody has a mania or somebody is just going through hypomania? And somebody has major depressive disorder. Also, there's a term that not very commonly used but called unipolar disorder versus bipolar, where you have mania and depression in terms of episodes. So we will see in detail about these different variations. Now, typically when I teach this class and when I talk about depression, I ask my students, how are you doing this last couple of weeks? How was it? And when you are asked this question, sometimes we are aware how your days are passing by, and sometimes we don't know much. In general, when you respond to a question like this, how are you doing? Let's say this is your normal mood. In another term, you don't feel super happy or super sad, right? You are not so, I think it's better to draw that this is normal. You have very, it doesn't seem, it's not happy, not sad. This could be super happy. This could be, like if you continue to the chart, this could be super sad, right? Now, if you ask somebody, how was your day? Let's say you take a couple days of chart in general, day 1, 2, 3, 4, and 5, the level of happiness or sadness can fluctuate. You were happy yesterday, you were okay the other day, and the other day you were a little sad, then you were happy again, then you were a little sad, then you have another few days of happiness, then it goes sad a little bit. That is normal. We go through normal ups and downs in life. That mood fluctuates to some extent. Now, what becomes a depression, what becomes a depressive neurosis, that's a very old term for mood disorder, is that people have this affect, the emotions that seem to last too long in one end, either this end or that end. So if I change the color a little bit just to distinguish, now somebody who is really going through whether major depression, the person could be sad for about 7 days and somewhat up and down and continue to remain sad. They have struggled to feel normal. So the sadness lasts for such a long time. And if you talk about people with bipolar disorder, that person could go through strong, not just happy, very elated mood, extremely happy, and it comes down, they don't remain normal or normal sad, they go through episode of depression. and this fluctuates, right? So you see the difference. People, those who have so-called depressive neurosis or affective disorder or depressive disorder, they tend to remain in sadness for a longer time. For a normal person, for somebody like you and us who does not have a clinically diagnosable depression, well, we go through ups and downs. We are happy when you achieve what you are planning for, and somebody passes away, something changed in your life, you felt sad, but that fluctuation is not too extreme, and that doesn't impair your daily activity, or it doesn't make you dysfunction, right? And it doesn't cause you distress. So it doesn't cause you extreme distress to the point that you're suffering. Now, that is what makes this depression very scary, right? It's like a strong deviation in mood. You're in one extreme that's hard to get out of it. And it is also manifested in terms of episode. So you have about 5 symptoms from the depressive disorder. I pressed 5 symptoms from the list that includes at least depressive mood or lack of interest in things that you used to enjoy. Now, one of them plus 4 additional symptoms is there present for at least 2 weeks. That's a long time. The person is sad for such a long time, and we call that a depressive episode. And on the other end, sometimes people experience manic episode, where you have at least 4 to 5 symptoms from mania, and that could last up to 7 days. So you are like a fleet of ideas. You have this constantly investing and taking risky move in life, financial, sexual behaviors, and lack of sleep. You don't feel like you need to sleep because you are so energetic. That lasts for 7 days. That's a manic episode. And if there is somewhat milder version of that, we'll look in detail, whereas you have less severe symptoms from mania, but it lasts about 4 days. That could be a sign of hypomanic. Hypomanic means below or milder version. So hypomanic episode could be there. And if somebody has these mood swings, that could deem diagnosis of mood disorder. And there are a few disorders that we will talk in this chapter. We will talk about MDD, major depressive disorder, persistent depressive mood disorder, that could be also known as dysthymia, that's an older term, and premenstrual dysphoric disorder, disruptive mood dysregulation disorder. Now we'll focus on maybe a little bit on this, but we'll also look at bipolar disorder as well. Now, depressive disorder are characterized in terms of courses and severity. Mood disorder can range from mild to severe. The most severe type of depression is called major depressive disorder. The first episode of major depression is usually time limited, often lasting up to 9 months if remain untreated. And bipolar depressive episodes generally last longer in compared to untreated manic episode. So those are a few distinctions you want to make. In these depressive episode can last up to 9 months. That doesn't mean you have episode for 9 months. It will be reoccurring. We call recurrent depressive episodes. And in compared to depressive episodes and manic episode, depressive episode seems to last longer, just like a previous example I mentioned here, 2 weeks versus 7 days. And even the untreated depression and mania, you will see depression lasts a lot longer. Now we'll go into one by one just to make it a little easier. What makes major depressive disorder? What constitutes major depressive disorder? Well, typically we have this misconception about, I am depressed or I am in depression. It could be a general, very colloquial term. But from clinical perspective, when you say somebody is depressed, we're talking about one of these symptoms is present. Number 1, depressed mood, which is nearly every day and at least for 2 weeks time. One of them is present. So one is a depressed mood, and the other one is loss of pleasure. The person who used to enjoy, the other term is anhedonia. The person used to enjoy many activities, but now the person has lost that interest. And in order to manifest an episode, one of them is present, either depressed mood or loss of interest is present for at least 2 weeks of the time. And in addition to that, you also see 4 additional physical or cognitive symptoms. And that could be, we can look at those symptoms. Now, if you look at the other physical symptoms, number 1 could be significant loss of weight. The person is starting to diet or gain of weight as well. There is an increase or decrease in appetite nearly every day. And if you think of children, they might not gain enough weight in compared to their age. And the other symptom is, so appetite is there. Let's make it simple. Appetite, right? Appetite is changed. And the other symptom you see is related to sleep. That's definitely physical sign that you notice the person is either sleeping too much, we call hypersomnia, or sleeping so little, insomnia, having trouble falling asleep. The other symptom could be psychomotor agitation or retardation. Again, nearly every day. Some people around the person can notice, or the person is reporting that feeling of restlessness, being slowed down, those symptoms. So psychomotor, appetite, sleep, psychomotor agitation. And the other symptom that you see in people is loss of energy. So energy is changing, and also feeling worthless. That's a significant amount of guilt, right? That could be delusional. It may not be due to any particular reason, and it could be due to actual some sickness the person has, or some loss the person experienced. And the other symptom is possibly concentration, poor concentration. And when you say concentration, becoming indecisive, the person is having trouble making decision in life that the person used to do super easily. And the other symptom could be suicidal ideation, planning or attempting to kill themselves by doing some kind of overdose of medication, drugs, self-mutilation, hurting themselves, so on. So to make it easy, how do we change this? How do we remember this? Well, I am taught in my undergraduate program, there is an acronym, SIG-E CAPS. S stands for sleep, I stand for interest, G stands for guilt, E stands for energy, C stands for concentration, A stands for appetite, P stands for psychomotor agitation, and the other S stands for suicidal ideation. So anytime you talk to somebody, if you remember SIG-E CAPS, you can check through your symptoms, and if person report at least 4 of these symptoms, you can get a sense that the person might have depression. And if that lasts for 2 weeks, plus one of these loss of interest or depressed mood, that is definitely a depressive episode. Now that is very important to diagnose somebody with major depressive disorder. And when you say major depressive disorder, we are only talking about depression. There is no mention about mania. Once we talk about mania, that actually takes us away from depression, major depressive disorder, and that will deem to diagnose with bipolar, because major depressive disorder is unipolar or only presence of depressive episode. Now, when you say mania, what does that mean? Well, we know that the person who has very elevated mood for such a long time, and that could include this grandiose planning. And when you think of mania, there is an elevated mood, expansive mood for at least 1 week. Now, we may not need 1 week of those symptoms if person is necessary to be hospitalized, right? If person has mania to the point it impose risk for his or her safety, that could also consider as manic episode. And when you look at the grandiose planning, there is a abnormally and persistently elevated and irritable mood, and that abnormality goes toward goal-directed activity and energy, and that could last for a week time. And during this time, what you see in this person is at least 3 or 4 symptoms. Now, if there is a irritable, then it is considered 4 symptoms. If there is no irritable, you just need 3 symptoms to exist for 1 week time. The person could have inflated self-esteem or grandiosity. The person thinks that he is, in this, indestructible, engaging in activities that could compromise his or her safety, decreased need for sleep, feeling rested after only 3 hours of sleep. That is scary because sleep is a very important part of well-being. And there is a lot of talk the person does, pressure to keep talking. It's not just the ideas, but the change in ideas. We also call, the connection with mood disorder, one term we use is flight of ideas, rapid speech and expressing many exciting ideas at once. I'm sure you have heard somebody when they're excited to share you some of their new ideas, but this is like ongoing, this flight of ideas is there. And these flight of ideas are subjective experience, and it's racing. There's thoughts are racing. It's so hard to keep it together, and they constantly engage in many tasks. Attention span is so short, and they constantly jump from one point to another that is coming from outside. We call external stimuli. That is either they tell themselves, they're like, I have so many ideas going on, I can't do one thing, I want to do 5 things at the same time. And increase in goal-directed activity. It could be either social or academic related, sexual activities, psychomotor agitation, that means purposeless or non-goal directed activity, fidgeting is visible. Now, when somebody is experiencing 3 of these symptoms, if there are 4, there's definitely irritability is there, then that could lead to impairment and distress. That's again necessary feature. And if somebody has these 3 to 4 symptoms present for 1 week, unless the person is hospitalized, we consider the person is having a manic episode, right? And this too much involvement, this a full manic episode could also happen during medication. If it is due to medication, then we don't diagnose, but at least we know now when you say mania, it's not just like talking a lot, not just thinking too many ideas, but a combination of multiple symptoms. Now, what if somebody has lesser feature? Somebody has similar manic symptoms, but there is shorter and less severe version of mania. In DSM-5, that is termed hypomanic, and that could last up to 4 days. And there are fewer and milder symptoms. In terms of symptoms, they're not too strong, and it could also associated with less to no impairment. So if somebody is experiencing hypomania, the person may not be at risk of hospitalization or impairment. In a way, the person could still function well and may not be problematic on itself, but it usually happen when somebody has this problematic mood disorder. So what is the problem here? Why do we consider hypomania as a problem? Well, when you have depressive episode, sometimes people go through some symptoms of mania. That's where they are hypomanic. And when you say mixed feature, the term for a mood episode with some elements reflecting the opposite variance of mood. So it could be depressive episode with some manic feature and manic episode with some depressive features. And they are generally less severe. That's why it doesn't cause problematic outcome. It doesn't impair per se. Now, for example, somebody is writing a whole bunch of articles who is happened to be a graduate student and wanting to publish that book and thinking that he will get the bestsellers award, that could be hypomanic experience, right? If you are constantly engaging in this activity, that necessarily does not lead to a problem. So that's what makes hypomanic shorter, lesser severe in compared to mania. Now, I'm assuming you're able to tell the difference between depressive episode, manic episode, and hypomanic episode. Before I ask you a question, let's talk about what is unipolar mood disorder. Now, only one extreme of mood is experienced. Now, when you say unipolar, that term applies. We're just talking about one of those mood problems. And it could be either depressed or a depressive or manic episode. Well, it's hard because mania is hard to experience, or the other better way to put it is it's hard to find a person who only experiences mania. In mood, you always have the very elevated mood and you come back to normal and you don't experience depression is extremely rare. What is common, is that the person who experience depressive episode, the person also more than likely to experience mania if the person has bipolar disorder. But if you have only depressive episode and you never experience mixed feature like manic symptoms or hypomanic symptoms, we diagnose that person with major depressive disorder. Now, depressive episode alone is more common than mania. So that's like what we're trying to explain here. Sometimes people argue, hey, what if you only have mania? Well, that's good, right? If typically people don't seek medical treatment when they are in manic episode. Why? From the symptoms, that the person thinks he or she is grandiose. The person doesn't feel like need help unless the person has to be hospitalized. Now, moving on, when you think depressive episode, it's more than likely that person will have more than one episode. In lifetime, the maiden number of major depressive episode could be up to 2 to 3 times in lifetime. And when you have both of them, the unipolar disorder doesn't fit the definition. That's where you have to talk about bipolar disorder. By definition, bi means there are two ends of the mood extreme experience. One is depressed and the other one is elevated mood. And there are some depressed episodes and some manic or hypomanic. That is where we talk about bipolar disorder 1 and bipolar disorder 2. We will talk about these two disorders in detail in a minute. Now, let me ask you a question here. Okay, so we know 3 different types of episodes: depressive, manic, and hypomanic episodes. There's a new diagnosis in DSM-5 that is called persistent depressive disorder. It used to be called dysthymia, which means a state of mild low mood. Dysthymic disorder is now it's a little outdated term, and it could mean like no major depressive episode. Now it is replaced by pure dysthymic syndrome. When you say persistent depressive disorder, which is called dysthymia before, that is different from major depressive disorder, because people who are diagnosed with this persistent depressive disorder have symptoms of depression that are long lasting. Now, let me be clear here. Persistent depressive disorder is not a milder version of depressive disorder. It is very confusing because persistent depressive disorder is a term that means any depressive mood disturbance that lasts for the majority of days across 2 years for adults and at least 1 year for children. And as a result, many different presentations can be accurately called persistent depressive disorder, including mild low mood lasting for years, a major depressive episode lasting for a year, or multiple major depressive episodes occurring against a background of more mild depression for years. And that's what you want to be careful when you use persistent depressive disorder. That person could have major depression and persistent depression, we call double depression, for over 2 years time. And that could be the person experienced those symptoms and there is symptom free time no longer than 2 months, and this is persistent unchanged over 2 years, and these people can suffer over 20 years with such symptoms. And it could also include severe major depressive symptoms, that symptoms that we found in major depressive disorder. So what are they? Well, when you say pure dysthymic syndrome, we're talking about mild depressive symptoms without any major depressive episodes. It's a pure dysthymic syndrome. Why? The person does not experience episode of depression. And this other term that you need to keep in mind is double depression. There is mild depressive symptoms with additional major depressive episodes that could happen or happening intermittently throughout 2 years time. So when you have mild symptoms plus depressive episode, we call that double depression, right? And that could last for 2 years. That's what qualifies PDD, persistent depressive disorder, or pure dysthymic syndrome. Now, when you look at the symptoms, it looks pretty much similar to what we talked in major depressive episodes. There is a presence, at least depressed mood, or two of the following: poor appetite or overeating, insomnia or hypersomnia. Now, low energy or fatigue, low self-esteem, poor concentration, feeling of hopelessness, and that could last for 2 years time. And it could range in terms of severity, mild, moderate, or severe. That could also have mixed feature, like you have anxiety distress, or you have melancholic feature, atypical feature, which we will see in detail. There are some features that could accompany. So anytime you say persistent depressive disorder, we're talking about little complex mood disorder than just like new disorder. Now this figure should give you a little bit of idea. It shows that the horizontal axis represents time and the vertical axis represents mood. So if this is mood, this is time, you see that the person is going down, and panel A shows that a non-chronic major depressive disorder that is recurring. So this is one episode, there is a period without the depressive episode, and there is another episode, right? And again, all of them should last 2 years to diagnose with persistent depressive disorder, or better term could be a double depression. And B shows that there is persistent depressive disorder with a pure dysthymic syndrome. Now the person is not experiencing episode there, right? But the symptom lasts for a long time. This depressed mood, loss of self-esteem, and feeling sense of hopelessness is there for a very long time. These are for about 2 years. No depressive episodes, but very long time sadness. And there is a sadness, and time to time the person experiences episode and again goes back to sadness. That is again another form of possible PDD. And here this is depressing to see this figure. Like D shows that when you look at panel C, there's a chronic major depressive episode. That person could not get out of a depressive episode. It's a very long time, and there's a chance that these individuals are more likely to attempt suicide in compared to other folks. They all have symptoms, right? Suicidal ideation. And panel E shows that there is a major depression and it's a partial remission. That means there is some level of less symptom, but still there is persistent sadness is there. And panel F shows that there is a depressive episode and without full inter episode, There is a recovery. That means the person did not recover from episode. There was a persistent sadness and another episode, which is similar to this one, but slightly different in terms of timeline. Now, that if you look at these different types of possible depressive disorders, it could make you mindful. How do you help those individuals? Well, we'll see some treatments, some medication that could benefit. Before we move on to that, let's look at some possible specifiers that makes the concept, the depression, more interesting. I mean, when I say interesting, it's not in a fun way, but it can accompany many features. There could be, we call specifiers. There's additional diagnostic label we use in terms of conveying extra information about symptoms, and the specifier are not necessary to diagnose with one disorder. It just helps clinicians to work with them. For example, if somebody presents psychotic feature, what does that mean? Well, we're talking about anytime you say psychotic, there are two terms that comes to your mind. One is delusion, the other one is hallucination. This psychotic feature, when you say hallucination, there's a sensory experience in the absence of sensory input. Another better way to explain that, well, there is no sound, but you hear different voice from God, different voice from other planet, alien, so on. There is no any sensory input from your eyes, but you see images. You see the God, you see the different objects, so on. So without sensory input, you interpret, you are seeing, hearing, feeling things. That is hallucination. Delusion, nothing better than hallucination. It's not a milder version, but there is a inaccurate belief that people hold, strongly held inaccurate beliefs. Now that could be, there is a sensory data, you see a picture, but it's a static picture, but the person who has delusion could be he or she is noticing that picture is moving. You do hear siren, you do hear cops driving on your street, they're not coming for you, but people who experience delusion might think, oh my goodness, they're gonna get me, I'll be in prison because they think they're spying on me, and so on. So that's delusion. You have this inaccurate belief about what you receive to your senses. That is one possible feature in depression. Anxious distress specifier, well, depression could also accompany with several significant symptoms of anxiety. We did see that, when you compare to symptoms of anxiety, you do have that possibility. You also experience some anxious distress, and that could predict poor outcome when you talk about treatments and intervention. And there could be mixed feature. When you say mixed feature, that could include several manic symptoms. Now you are experiencing not mania, not hypomania, but you do experience some of those symptoms, not to the point deemed diagnosing bipolar disorder. Melancholic feature is like major depressive episode accompanied by additional severe symptoms such as early morning awakenings, lack of reactivity to positive stimuli. The person is almost like lost in their mind. They could not show that positive reaction, and difficulty enjoying everyday activities. Catatonic is another feature. There is an extreme, rare muscular symptoms such as remaining in a stopper. Your body parts are remain in same place, and when you try to move, it's hard to move. Now this is another extreme case of depression. Individuals do not even take care of hygiene, difficulty getting up and using bathroom, cleaning themselves, doing things that normally people would do. And they also could show that repetitive or purposeless movement, almost unintentional. And if you think of a person who is lying immobile for a long time, and if someone moves her arm to a different position, the person remains the same, and the person stops talking and stops listening to you, you can see that there's a catatonic feature in that individual. And atypical feature could be presence of several symptoms less common in depression, but it could be oversleeping or overeating. That's like an atypical feature. And peripartum onset is that happens around the time of giving birth. In a person, especially in women who are going through pregnancy, this could happen around, when you say around, it could be before or after pregnancy. And in tragic cases, like there are reports that mothers who are going through major depression during this, with this peripartum onset, could even murder or kill their children, their babies. So it's in the very tragic cases those are possible. And seasonal pattern that you see is depression that is happening primarily in certain seasons, usually in winter. The most usual pattern of a temporal specifier in major depressive disorder happens in the late fall and ends with the beginning of spring. So could be right now we're talking about, right? And there's a special diagnosis called seasonal affective disorder. Now, when you think of these different specifiers, it should give you a little bit of idea that depression could be very complex, and it could hit individuals in many ways, not just with the diagnosis, not just with the depressive, manic, and hypomanic episodes, but also with these qualifiers or specifiers that makes treatment a lot complex. And no wonder researchers, scientists, they continue to find better way to treat these individuals. And we'll see some of the effective treatments that has been developed for depression. A couple more ideas before we end today's this lecture session is that onset and duration of depressive disorders. In children, it's hard. You do see that children could be tearful, they have these mood swings, and those symptoms will disappear really fast. And in a term we call baby blues, right? Those symptoms you see in young children who are super, 4 days old or 7 days old, 1 month old. You do see that. However, they don't have an ability to experience full-blown depressive episode. Now, if you look at the symptoms, it makes sense. It might take some time, at least to their adolescence age. And risk increase in adolescence and young adulthood, but it goes down during middle adulthood, and again it increases in older age. There is like a U shape. Now, why does that happen? Well, there is a major shift in children when they are turning to adulthood. And adolescence is a very confusing age period for children. And in that confusing time, if you did not receive sufficient social support, education, psychoeducation part, what you go through could be a dangerous precursor for children to experience depression. And if you look at the chart here, what leads to develop, we'll talk about causes, the etiology, but parents with dysthymic disorder and major depressive disorder seem to have higher score of depression. So if you look at these children, the children tend to have more chance of developing disorder, especially this double depression. And parents with pure dysthymic disorder, only PDD, they seem to have somewhat in between chance of developing disorder. Patients with non-chronic major depression that seem to have not so often, you tend to develop depression. So, well, it's useful to keep in mind that young children now, the onset is about 12 to 13 years old for depression. There's a chance, but also worth considering the parental psychopathology history when we talk about onset for children. And it could vary in lengths, right? Untreated depression could last several years. We saw that PDD could last about 20 years, and MDD, major depressive disorder, could last about 9 months with multiple episodes we call recurrent. Now, besides these possibility that children could have symptoms of depression, and there were time children were diagnosed with bipolar disorder because people thought that they are experiencing manic episode. However, studies found children could not experience manic episodes because they constantly engage in mind games, imaginary games. So it could be misdiagnosis. That's why there is a new disorder in DSM-5. It's called disruptive mood dysregulation disorder. That is to reduce children used to be diagnosed with bipolar disorder 1. Now they replaced with disruptive mood dysregulation disorder because lack of mania. And it also should reduce number of bipolar disorder, and following with so much medication, it's extremely strong and major side effect in depression, because in terms of treatment, it's hard to find proper treatment for children as much as you would use for adults. So keep in mind that we're not talking in detail about disruptive mood dysregulation here, but keep in mind children cannot have manic episode. That's why there is a new diagnosis called disruptive mood dysregulation. Now, one last slide. When you talk about depression, it's hard not to talk about grief, right? In DSM, an earlier edition before 5th edition, depression could not be diagnosed during period of mourning. Like if somebody is moaning, symptoms could be similar to depression. Now, what makes it different from depression, though? If somebody is grieving for a loss, what makes it unique? Now, study shows that people who have depression, the sadness, the suffering comes from themselves. It is related to their past, unable to find meaning in their life, unable to engage in activities that they used to enjoy. However, in grief, it might just because of your connection, the person's connection with the person who died. If even sometimes people who are grieving could think of committing suicide. Now that could be just because the person is willing to connect or join with the dead person, rather than ending the life because the person doesn't find any meaning. So just to change that, now in the DSM-5, it's recognized that major depression may happen during the grieving process, and generally not considered psychopathological when they are associated with grief reaction. But now we do look at acute grief, that happen after loss, and integrated grief, coming to terms with meaning of loss, or complicated grief, persistent acute grief, and inability to come to terms with loss. Now, when you see these changes, we are trying to identify whether the person is experiencing other symptoms as well. Let's say somebody is experiencing depressive symptoms during the grief period and also have auditory hallucination. Well, there is a chance that person has depression, or something is related to, let's say, some person lost an animal or beloved person and not willing to move on or replace the dead, the lost pet, so to call. Well, that could be not pathological, right? If somebody is having depressive episode but also have paranoid delusions, or unable to move on with the life and willing to keep the person's dead body, well, that could be a possible diagnosis with depression. Now, rather than just excluding grief from depression, now we try to see if somebody is having this acute, integrated, or complicated grief in definition, and we try to identify those different types before we make diagnosis. Again, the bottom line in this slide is that grief used to be out of concern for the diagnosis. Now, major depression can happen during grief period, depending on if the person is experiencing additional symptoms that is beyond what is defined by grief, which is the person is not just nostalgic about the loss, but also experiencing other symptoms that is under specifiers or the diagnostic criteria of depression. One more depressive disorder to discuss here is premenstrual dysphoric depressive disorder. Now, this PMDD is not just a typical PMS symptoms experienced by many women Rather, it is reserved for symptoms that are unusually severe, sometimes numerous, persistent, and interfering and distressing. Now, if you if you look at why we should include this disorder or why should we not, well, it may sound somewhat sexually or gender wise. You might consider, like, why do we need this, because this is more specified for female. Well, it's a matter of question. I want to ask you, what do you think? Are you for or against including PMDD in DSM-5? Well, when you say premenstrual dysphoric disorder, there is a significant depressive symptoms happening prior to menses period, and the majority of the cycles leading to distress and impairment. Now, keep in mind, when you talk about mental disorders, we always look at whether the symptoms that person experiences leading to distress and impairment. Now, if you look at the symptoms, there is a mood swing, sensitivity, irritability or anger, depressed mood, anxiety and tension, decreased interest in usual activities, difficulty concentrating, lethargy, change in appetite, problem in sleep, feeling out of control, and physical symptoms associated with PMS. Now, if person is experiencing, in addition to you need at least 5 symptoms here. Now, if you think any of these are related to physical symptoms, but there are some psychological symptoms as well. And if somebody goes through this more often during their PMS cycles, that could deem diagnosis of premenstrual dysphoric disorder. Now, there is an advantage of using this diagnosis. That's one factor you want to consider. And it's like controversial diagnosis, but the advantage is that it makes the female problem that they go through, especially during the menstrual period, it legitimizes the difficulties that some women face when symptoms are very severe. The other problem, the downside, is that it is in a way pathologizing an experience many consider to be normal. Now, maybe we are overthinking here, or we are just trying to find a better way to put it in certain terms. In either situation, of course, in any diagnosis, there is a fear of stigmatizing, but also worth considering, what if we can use these diagnoses to help women, those who experience not just physical symptoms, but also psychological symptoms that make their life difficult, and that might benefit from the diagnostic perspective. If you remember talking about, why do we need diagnosis? Well, we're trying to find help. We're trying to use fund their treatments and consider that these are legitimate concerns. So these diagnoses, keeping in mind what makes one disorder different from another, will help us to develop a better picture. When you talk about major depression, persistent depressive disorder, disruptive mood dysregulation, and we will talk about bipolar disorders, we're trying to compare them and also understanding how severe this disorder could be. When we talk about those specifiers, you might notice, it could be extremely dangerous. And now we know that why a depressive disorder is strongly associated with suicidal ideation and suicidal attempts. So we'll look into more details in that in next video. And let me ask you a couple of questions here. And in next video, we'll talk about bipolar disorders and also causes and treatments for mood-related disorders.